video for those who can't come.
Fantastic.
Starting the recording right now.
Okay, great. Well, thank you very much for inviting me to come and give this webinar. I'm talking from Bart's Hospital in London, which has several claims to fame. Firstly, it's one of the oldest hospitals in the world. There's actually been a hospital on this site since 1123, so for some time. And it's recently been kind of revamped. And we now have the largest cardiac centre in the UK here. We've got 10 cath labs, 10 cardiac theatres, 3 dedicated cardiac MR scanners. And we also have the London's second largest cancer centre. So we're really been in an ideal position to set up a cardio-oncology unit, which we did a couple of years ago. And I've now got 3 colleagues working here with me. And we're seeing really increasing demand from both the oncologists and the haematologists. But I'd like to start off, by introducing this case, which has caused me some difficulties over the last 18 months or so. This is a 74-year-old gentleman who I initially saw back in January 2017. He'd been admitted via the emergency department, and he was referred to me by one of the haematologists. He'd described increasing shortness of breath, fatigue, and peripheral edema, gradually getting worse over about a 12-month period, but had got significantly worse over the preceding 2 to 3 weeks, leading him to go to the emergency department and to be admitted to hospital. In his past medical history, he had a history of paroxysmal atrial fibrillation, and he was anticoagulated for this and had had previous cardioversions and a previous successful cryoablation for his atrial fibrillation. He also had treated hypertension and had also had multiple small pulmonary emboli despite his anticoagulation for his atrial fibrillation. Of particular note to us, he had a background history of acute myeloid leukemia, which had been diagnosed in 2014, and for which he'd undergone allogeneic stem cell transplantation, which he described as being relatively straightforward. And in his own words, he said he sailed through. So despite his age, he'd obviously had a relatively uncomplicated course through his stem cell transplants. Since his stem cell transplant, he'd had some mild pulmonary and ocular graft-versus-host disease, but had been followed up with regular lung function tests, and there'd only been a really fairly subtle decline in his lung volumes and his diffusion capacity. He also had some ocular GVHD, but that was relatively well controlled on eye drops as well. So he was on a fairly predictable cocktail of medications. He was on the anticoagulation with apixaban for his atrial fibrillation. He was on standard post-transplant penicillin prophylaxis. He was on a small dose of frusemide, which his general practitioner had put him on because of the increasing shortness of breath. And then he was on inhalers and eye drops for his mild GVHD. He was living independently at home, although over the last kind of 3 to 6 months had been finding it increasingly difficult. His partner at home had various other medical conditions, and so he was helping to care for her as well, and he was finding this increasingly difficult. And this had become more of a problem, leading to him seeking hospital admission. So when he was initially seen, he was tachycardic with a heart rate of 110 beats a minute, but he was in sinus rhythm. His blood pressure was a little on the low side, and he had oxygen saturations of 92% on air. On examination, he had elevated JVP, but his heart sounds were relatively normal. He had crepitations throughout both lung fields and small bilateral pleural effusions, but he was noted to have peripheral edema to his mid-thigh. So he had standard investigations in the emergency department. His chest X-ray confirmed that he had evidence of pulmonary edema, and his ECG just really showed sinus tachycardia. There was no ischemic changes and nothing else particularly remarkable on the ECG, just sinus tachy. His baseline bloods on admission showed a normocytic anemia, But this was fairly stable. He'd been under constant follow-up from the haematologists, and his hemoglobin had been stable over the preceding 6 months or so. His white cell count was normal, and the differential and his blood film were unremarkable. And the haematologists were happy with how he was from his leukemia point of view, and were happy that he'd essentially been cured from his leukemia after his stem cell transplant. He had slightly elevated inflammatory markers, and his renal function was mild to moderately impaired. He had EGFR estimated at 45 mils per minute on his admission bloods. But his cardiac biomarkers were slightly abnormal. His troponin was just above the upper limits of normal, but his BNP, as you can see, was really grossly elevated. Normal limits are in brackets on this slide. So this was his admission echocardiogram. As you can see, he's got a pleural effusion. He's also got a pericardial effusion, which in the parasternal and apical images doesn't look significantly large. But when we looked in the subcostal images, you could see that there was some RV collapse and right atrial collapse. And given his clinical state and the echocardiographic findings, the decision was made to go and do pericardiocentesis. So this was done uneventfully, and 350 mils of bloodstained fluid was removed. He was then put on the coronary care unit and started on intravenous diuretics as per standard procedure for patients with pulmonary edema. The question then, of course, was what was the cause of this pericardial fluid? We've got a patient who had no significant preceding cardiac history apart from atrial fibrillation. He had no recent history of infection or travel, but he did have a background history of AML, had been previously immunocompromised, and had some mild extracardiac GVHD. So we sent off a full virology and autoimmune screen, not only on his bloods, but also on the pericardial fluid. Importantly, we spoke to the haematologist before we sent the pericardial fluid off, because they wanted to do full immunophenotyping and cytogenetics to make sure that there was no evidence of recurrence of his AML. There were a few case reports suggesting that you can get a recurrence of AML in the pericardial fluid, and so we wanted to make sure that that wasn't the cause, even though everything else from the hematological perspective was normal. They also wanted to go on and do a PET scan, which they did, which proved to be negative, and they also did a bone marrow aspirate, which again was negative. So there was no evidence from his pericardial fluid, from his bloods, or from his bone marrow aspirate that there was any recurrence of his AML. So what are we going to do next? Well, the first thing we did was have a look at his echocardiogram following the pericardial drain. So this was about a week later. You can see that the pleural effusions have reduced, the pericardial effusion is essentially all bit gone, and his systolic function looks pretty much normal. What was noticed, however, was that there was some thickening of the pericardium, really in all the walls, and there was mild bilateral dilatation. But I suppose almost most remarkably, given this patient's age, he had evidence of a high E wave and a smaller A wave on his transmitral Doppler filling pressures. This was his tissue Doppler profile, and we can see that he had high E prime velocities, again slightly surprising for his age and his history of hypertension, with E prime values of 13 in the lateral wall and even higher in the medial wall at 15 centimeters per second. When we then had,
it's kind of interesting. You have a lot of respiratory variation on the lateral wall there.
Yeah, exactly. And then certainly when we looked at the transmitral and transtricuspid inflow patterns with respiration, you can see that there was a great deal of variation. So greater than 50% with both of these, probably most marked in the tricuspid filling profiles. So at this point, we were concerned that there may be evidence of constriction, given both the 2D appearances with the bright pericardium and then the abnormal Doppler and tissue Doppler profiles. So we went on and did a cardiac MR scan to see whether we could see any evidence of pericardial thickening. We're quite lucky where we are. We have access to MR quite easily, and so it's quite straightforward to organise for these patients. CT, of course, would have been an alternative, but we thought we'd actually get possibly more information from the MR scan about tissue characterisation in the myocardium as well. So this is just the HASTE stack, and you can see that there's still evidence of significant decompensation with bilateral pleural effusions, some very small lymph nodes, nothing significant, and he's got a very dilated IVC, you can see. In these initial planning pictures, you can't really see that clearly what the pericardium's doing, but when we move on and do the cine imaging, it becomes quite clear to see the pericardium. So this is the full chamber view. You can see that there's quite a lot of fat around the epicardium of the heart. He'd obviously had steroids for quite a long time, this gentleman, during the and around the time of his stem cell transplant. And actually, we found that patients who have had significant amounts of steroids, for whatever reason, seem to have large amounts of fat in this area. But it's really this pericardium here that you can see is really grossly thickened. This is about 15 to 20 millimeters thick in different areas. And it seems to go really all the way around the heart and completely encase the heart. And it almost becomes easier to see on this short axis stack, where you can see all around the heart there's this thickened pericardium. And actually, it's quite striking that we get such beautiful images of the mitral valve. My kind of rule of thumb when I'm reporting these scans is that if you get these beautiful images of the mitral valve, it tends to mean that your patient's got no long axis function whatsoever, because normally you're coming in and out of plane. So this was telling me this patient really had kind of relatively poor long axis function here.
Did he ever get any whole body or chest radiation?
So he hadn't had any radiation around the time of the stem cell transplant. He hadn't been given whole body radiation as part of his protocol, no. So these are the late GAD images, and again you can see that the pericardium is thickened. Of note, he also had edema imaging, both with T2 weighted stir imaging and T2 and T1 maps. And his values were essentially normal, and there was no evidence of any myocardial inflammation. So this purely seemed to be pericardial. And then when we did dynamic real-time imaging with inspiration and expiration, it's a little bit difficult to see, but you can see there's a slight septal flattening with inspiration. So as the diaphragm goes down, the septum flattens slightly, suggesting that there's some ventricular interdependence. So how do we manage him going on from there? We've got a patient who has had a pericardial effusion and has clear pericardial thickening, but we're not quite sure what the cause is. Treated him with diuretics, and he was discharged home on kind of reasonable doses of oral diuretics, but we still hadn't got an obvious cause. So the decision was made partly driven by the hematologist to do a pleural drain and lung and pleural biopsy to look for lung GVHD, as to see whether this was the potential cause. And this found mild GVHD in the lungs. And so based on that, they started the patient on relatively high doses of prednisolone, and then also on mycophenolate as a steroid-sparing agent. And the hope was that this pericardial thickening was simply the result of GVHD, and that it would respond well to their immunosuppression, and that his symptoms would improve. Unfortunately, things didn't quite turn out that way. He had 2 further prolonged hospital readmissions with peripheral edema and pulmonary edema, and his functional state was declining quite significantly. So he'd gone from being completely independent, helping to care for his wife, to actually having to be admitted to a nursing home when he wasn't in the hospital. And his functional state had gone from functional state 1, essentially, to ECOG 3 to 4, and his NYHA status was 3 to 4. And he was spending most of the time in bed and most of the time sleeping. So he'd really deteriorated a great deal in the 6-month period. He we did repeat imaging, both cardiac MR and echocardiography, and there didn't seem to be any improvement in his constrictive physiology, and his pericardial thickness hadn't changed, so he still had significant pericardial thickening despite the immunosuppression. He had a CT scan, there was no evidence of any pericardial calcification. So we were really in a position where we had two options. One was palliative care, discharging him home with palliative care support. And the second was thinking about doing pericardial stripping, which is obviously quite a big step in a patient whose functional state was so poor. And the other issue with doing the pericardial stripping, this gentleman, was that if GVHD is the cause, or was the cause, and we haven't got it completely under control, were we going to get recurrence of the GVHD in the pericardium despite pericardial stripping? So he went for a coronary angiogram, which showed that he had got significant coronary artery disease, but the real reason for doing the cath was to do the right heart study. You can see he's got quite good collateralization, and actually the right coronary backfills from the left system. And he'd never described any chest pain, and a myocardial perfusion scan had been negative. So he'd obviously kind of coping quite well with good collaterals. His right heart study, and I'm afraid I don't have his traces, but I've got the measurements. He had raised right atrial pressures with prominent X and Y descents in his right atrial pressure trace. He had low cardiac index, and his LV and RV end diastolic pressures were elevated and equalized in diastole. And kind of possibly most pathognomonic, he had an increase in the area under curve of his RV pressure with inspiration and a reduction in the LV pressure. So this is really all kind of pathognomonic of the constrictive physiology. But the reason for doing the study was really to allow us to get a better grip on kind of how severe this constriction was.
Well, I think the echo findings with the tissue Doppler varying on the lateral wall is very concordant with what you found on the right heart cath.
Yeah,
it's very difficult to see that kind of respiratory variation in the lateral wall Doppler, tissue Doppler, unless you have some sort of either severe respiratory difficulty or constriction.
Yeah, no, agreed. So we basically had a meeting with cardiac surgeons, hematologists, us, and the intensivists to decide what we felt was the most appropriate course of action. And I think everyone felt that this gentleman was only 74. He'd flown through his allogeneic stem cell transplant, and therefore we kind of had to give him the benefit of doubt and go towards pericardial stripping. And these were the images that the cardiac surgeon took during the operation. So this here is the pericardium as he cuts through it, and you can see that it's kind of thick and fleshy and not the kind of nice thin film that we're used to seeing when we see a pericardium. Unfortunately, as we know, the pericardium was thickened all the way around the heart, but the decision was made to do only a partial pericardectomy, just kind of from phrenic nerve to phrenic nerve, because we were quite unkeen to put this gentleman onto cardiopulmonary bypass because we weren't sure that we'd be able to get him off again. And in fact, the intensivists said that and the anaesthetists said that they would not take this patient on if he'd ended up going onto bypass. And so the decision was made to just do a partial pericardectomy and not to do anything about his coronaries and not to put him on bypass grafting. But you can see here where the diathermy kind of burns are. You can see how thick that pericardium is. But having stripped it away, you can see that the heart is moving quite freely. But round here, obviously, there was still pericardial thickening. So as I said, the reason for not going ahead and doing either coronary artery bypass grafting in addition to the pericardectomy, but also not being willing to put him onto bypass was really because of the high mortality and complications associated with pericardectomy. This is probably the most recent relatively large study of pericardectomy which was from a German group in Leipzig, and they found an 18% 30-day mortality, and this is in all patients, so not cancer patients, but in all patients. And if you go ahead and do other surgery, be it bypass grafting or valve surgery at the same time, your mortality is so much less than, I mean, so much greater than in patients who are having pericardectomy alone. And this is another study published a couple of years before that from Johns Hopkins, where they showed that the most predictive marker of mortality in pericardectomy is the need for cardiopulmonary bypass. And those patients that ended up needing to go on to bypass had a 20-fold increased risk of death. So before we even went into this patient's surgery, we'd made an active decision that he was not going to go on to bypass unless strictly necessary, and therefore he was only going to have a partial pericardectomy. So how's he getting on? Well, he still is on high dose of oral antidiuretics. He's now 12 months post-operative. He's on bumetanide 3 milligrams BD and spironolactone. The hematologist has started him on ruxolitinib as well as his mycophenolate mofetil for graft-versus-host disease. Ruxolitinib, there's new drug trials coming out for this in GVHD. So the efficacy is still a little bit unproven, and it's a relatively new agent for this indication, but the kind of early trials are hopeful that this is going to offer something for these patients. But I think most striking, he's significantly better. He's NYHA class 2, he's functional stars class 2, and he's living independently, and recently was able to get married to his long-term partner. He's living at home, he's well out of the nursing home, and he's had no further hospital admissions. This is his most recent cardiac MR scan. And you can still see that there still is some pericardial thickening. The RV is nice and free where the pericardectomy was performed. But there is still pericardial thickening, and you can see that the septum is still bouncing, suggesting that there's still some evidence of ventricular interdependence. But by and large, he's significantly improved compared to how he was. And a really quite a good example of where we had no options. Pericardectomy wouldn't necessarily have been my first choice for him, but it does seem to have worked quite well. Unfortunately, in the last 2 months, I've been referred from the same hematologist, another patient. This time she's a 40-year-old female.
Yeah, once you have a little success, you know, all good deeds are punished further.
I know. She's a 40-year-old female, farmer's wife with 2 young children. She was diagnosed with AML, which was relatively refractory, and she was treated with a myeloablative allogeneic stem cell transplant back in March 2016. Both her peri-transplant course and her subsequent course has not been so smooth. She had really severe, both acute and chronic graft-versus-host disease, particularly involving the skin. She's got terrible sclerodermic skin GVHD, which has significantly impaired her quality of life and kind of made everyday activities really very difficult for her. She was saying that her children have all started at new schools, and she can't bear to go to the school gates because all the children and the other parents kind of stare at her because it's so pronounced. This is obviously not her. I didn't want to take pictures of her for obvious reasons because she's extremely self-conscious of her appearance. But just to make the note that the sclerodermic changes with graft-versus-host can be really nasty and really debilitating for these patients. The scarring, the tightness, the joint dysfunction, it causes significant distress to these patients. And she's having oral cyclosporin and regular extracorporeal photopheresis, as well as topical tacrolimus, but it's not really hitting her GVHD, and she's still got significant problems from it. I was asked to see her because she'd been complaining of palpitations, and the nurses, when she'd been having her ECP, had said that she was continuously tachycardic. She had a Holter and an ECG, which were unremarkable and just showed sinus tachycardia throughout both day and night. So she had nighttime sinus tachycardia as well, which kind of always worries me a bit. She was complaining of fatigue and mild shortness of breath. She was limited in her exercise capacity, but not just by her shortness of breath, but by other symptoms as well. And she was probably NYHA class 2, and her functional state was 2 to 3. But notably, from all her investigations, her NT-proBNP was really extremely elevated. her echo images are not great, so I'm afraid I haven't shown them. But with her, again, we can see that she's got fairly gross pericardial thickening and the whole heart fairly encased. And this is on the left, the T1 weighted imaging, on the right, the late GAD imaging. And you can really see that it's thick all the way around the heart, this pericardium. And on her, probably even more clearly than the previous gentleman, you can see the septal flattening that you get with inspiration, suggestive of the ventricular interdependence. So she's clearly also got pericardial constriction, and almost certainly in her, we don't need to think really about getting any tissue diagnosis. This will be because of the GVHD, given the fact that we know that she's got such marked sclerodermic GVHD. But obviously she's got extremely active disease, and therefore operating on her potentially not, A, she's going to be severely limited and her risk perioperatively is going to be quite difficult, but B, the active disease would make the hematologist and myself extremely concerned about doing a pericardial stripping in her. So the decision was made to try and change her immunosuppression, and she's been put on very high doses of oral steroids. Her cyclosporin dose has been increased, and she's having more ECP than she was having before. And we're only a month down the line. She's been treated as an outpatient. There has kind of, with an eye of faith, there's been a slight improvement, a slight reduction in the thickening of her pericardium. So I don't know, we'll have to watch this space and I'll be able to feed back how she gets on. But this was the second case in a relatively short period of time of someone with GVHD-related constrictive pericarditis. And these were the first two cases that I'd ever seen, and it was not something I really knew about. And then we're looking through the literature. There's only a couple of other case reports, but this one actually comes from the Brompton in London and was published in Circ Heart Failure last year or the year before. Again, a case of a young patient with GVHD who had pericardial constriction, but that responded extremely well to immunosuppression, and the patient was essentially had no further evidence of constrictive physiology and did extremely well. Good. Do you want to, sorry, Dan and Eric, do you want to discuss the case at all before I move on to a couple of other slides? Or?
Sure. I mean, you've presented some really sophisticated things here, but and especially all the images are really amazing. The you know, my only one comment on the second case would be, you know, at some point in time, I would probably, you know, go towards a right heart cath looking for evidence of pulmonary hypertension, because you may choose to modify your treatment based on the sort of scleroderma-like, you know, nature of her GVHD.
Yeah, no, that's a good point. I think that's a good point.
But I think that, and she had that, you know, D-shaped septum, and it looked like her RV was a lot more dysfunctional than your first case.
Yes.
And
yeah.
so I think that pursuing whatever you can do to decrease whatever increased pulmonary vascular resistance she has, that might be one avenue. I don't know if that's the case, but that would be.
I hadn't thought of that. That's a good point.
But I mean, I have to say that the first case is just kind of amazing that you went all the way down the path to even do the pericardiectomy. That takes a lot of guts, because as you showed from the results of a pericardiectomy, it's not very good.
No, it feels as though it's just been enough to keep him out of hospital and keep him with a quality of life that is acceptable, which he certainly didn't have beforehand. So in some ways, I suppose it's a palliative procedure really, rather than a kind of curative procedure. But I think the other thing that's quite striking is that the immunomodulation and immunosuppression that he's getting seems to have prevented the rest of his GVHD getting worse. So kind of the risk was worth taking.
Yeah, well, I think that the fact that he's still alive is testament enough to that. But, you know, because the way that things were going, he wasn't going to be alive for very long.
No, no. I mean, his long-term outlook is still not great, but he's 12 months down the line and is enjoying an acceptable quality of life.
Yeah, well, I'd say that's 12 more months than he was going to have.
Yeah, yeah.
Charlotte, let me ask you, did his NT-proBNP improve post-operatively?
So his has improved post-operatively quite considerably. So I can't remember what it was beforehand, but it's now still elevated, but it's about 400 or 500 rather than being kind of, I can't remember, about 2,000 or something beforehand.
Well, that's a great improvement. And usually NT-proBNP goes up because of the systolic dysfunction of the pericardial constriction. And so if you relieve the systolic dysfunction, then the NT-proBNP will come down. So that's good information.
Notably, unfortunately, the second lady, even though she's had the immunosuppression, I actually measured her NT-proBNP again on Friday when I saw her, and hers has gone up. So I'm still not feeling confident about her. We'll see, but
yeah,
we'll
I mean,
see.
I think she could still be having a substantial amount of RV failure.
Yeah, that's a good point. I will definitely think about doing the right heart cath with her.
So I see the. Go ahead.
Yes, good morning, everybody. So that's like amazing. When I saw you took her to the OR and go, oh my God, the guy died in the OR. So I have 3 comments. One, you'll probably see a third case because everything comes in threes.
Yeah.
2, I think to reinforce the value of the physical exam in these people, and that I can't imagine that they didn't show Kussmaul sign, and hopefully one of them has a pericardial knock. So I think you think about MRIs, but remember that like the lateral wall Doppler, you may make the diagnosis at the bedside without all the other stuff. And my experience here has been very few cases of actual constriction from GVHD, but a lot of serositis that includes the pericardium. And if you can treat people early, I think that you can prevent the progression to constriction. So that when people present, especially with skin GVHD, to try to be aware and to look for pericardial disease. So I think it changes the aggressiveness of GVH treatment when the pericardium is involved versus other, especially the skin. So this is much more common than everybody actually thinks.
I think that's a really good point. The last point is really important. I think hematologists, because it hasn't actually been published very much, hematologists don't think of the pericardium. It's not a particularly commonplace for patients to have GVHD, and so maybe in patients, as you say, who have got lots of skin involvement, lots of scleroderma, they should be thinking about doing a cardiogram, assessing the physiology at a relatively early stage, and not waiting until these patients present with confirmed, kind of marked, established constriction.
Yeah, I will say that just amazing cases that you presented and all the information, et cetera, is super sophisticated. So impressive from London. Is that the hashtag that we have now?
I've just got a couple more points that I was just going to go through in terms of background. So obviously allogeneic stem cell transplantation has really kind of revolutionized the care of patients with refractory and acute myeloid leukemias and other hematological conditions. But unfortunately, GVHD is an almost inevitable consequence, because part of the beneficial effect from the stem cell transplants is the graft versus tumor effect, and it's the same alloreactive donor T cells that cause both responses. Acute versus chronic GVHD used to simply be classified according to when it presented, so before or after 100 days. But I think there's now an increasing realization that acute GVHD is mainly via apoptosis, whereas the chronic GVHD is fibrosis, and they actually think there's different cellular mechanisms that cause the two. It occurs in the majority of patients, particularly acute GVHD. And acute GVHD has not actually been described affecting the heart, it's only chronic GVHD. And I think it's also important to note that it's actually the leading cause of non-relapse mortality beyond 100 days. So when we look at the outcomes of stem cell transplantation, if you take out primary disease progression and infection beyond 100 days and at less than 3 years, 10% of patients who die, it will be because of GVHD. Of course, steroids are the standard of care, but ECP is used increasingly, particularly for patients with skin GVHD. But there are new immunotherapies coming out to try and help with this. But pericardial disease in cancer patients as a whole is something that we encounter very frequently. It forms quite a significant proportion of the patient group that I see, particularly in patients who present often with tamponade needing urgent treatment. It can either be a manifestation of their underlying malignancy, mesothelioma, sarcoma, lymphoma, probably the most common. This image is of a patient with an angiosarcoma. And this one is actually of a patient with Rosai-Dorfman disease, a histiocytosis kind of malignancy. And this is one of the few cases that's ever been seen or documented of Rosai-Dorfman disease with pericardial involvement. And actually this patient, they really didn't know how to treat at all, and initially gave some chemotherapy, and then nothing seemed to happen. And so he's actually been followed up now for 18 months and there's been no progression. So, and that's interesting in itself. But the other thing that we often see, and probably more commonly seen, is pericardial disease as a result of metastases. And this was a patient literally within the last few weeks who presented to us who'd had breast cancer, which she thought was cured. So she'd been treated 3 years ago and had had no metastases at the time, had been followed up regularly and had no evidence of recurrence, and then presented with pericardial tamponade. And actually when we got cytology back, it was primary breast cancer, unfortunately. But she also needed emergency pericarditis. But obviously, you can also get pericardial disease as a result of cancer treatment. I've talked about GVHD in the context of stem cell transplantation, but also quite a lot of the chemotherapy drugs can also cause pericardial effusions. Anthracyclines rarely can, but they can. High-dose cyclophosphamide can cause a hemorrhagic myocardial pericarditis, Atra, or transretinoic acid, which is used for acute promyelocytic leukemia, has also been shown to cause pericardial effusions quite commonly as a result of differentiation syndrome. And then, of course, in red, I've written the immune checkpoint mediators. This is something that more and more we're seeing and everyone's more aware of. And so I imagine that in the literature, we're going to see a lot more kind of observation and recognition of this as a problem with this patient group. This was a lady who was being treated for acute promyelocytic leukemia, who we saw last year, who'd had her first cycle of idarubicin and Atra and developed pericardial effusion and was quite symptomatic with this. She got quite a lot of chest pain and developed this pericardial effusion. And we've assumed that this was differentiation syndrome and the result of the Atra. So in the next cycle, we gave some steroids. The next cycle, withheld the Atra but kept going with the idarubicin, and unfortunately exactly the same thing happened again. She went from the pericardial effusion having gone completely to having a big global pericardial effusion, which very nearly needed pericardiocentesis, which was problematic because she actually had a platelet count of 6. So we weren't keen to do that if we could possibly avoid it. So in that stage, we decided that probably it was the idarubicin rather than the Atra that had caused this. So that was an interesting case. Radiotherapy obviously can cause pericardial problems, both pericardial effusions and then ultimately pericardial constriction. You often get this calcified pericardium, which you can see on the CT image here. And it's particularly common, as you know, in patients who have had mantle field radiotherapy. Generally presents more than 5 years after being treated, and it's obviously going to be dose related. And I suspect this is something we're going to see less and less of, to be honest, because modern radiotherapy, as you know, will restrict the dose that patients have. So both respiratory gating and modern radiotherapy techniques, 3D conformal and intensity modulated radiotherapy, will reduce the likelihood of patients developing this. But more generally, pericardial effusions in cancer patients are extremely common. Of all cancer patients, one study found that between 5 and 15% of patients will have malignant effusions, and about 7% will have non-malignant effusions, presumed either as a result of sepsis or intercurrent sepsis or treatment. And they generally confer a poor prognosis. So patients who have pericardial effusions of whatever cause only have a median survival of 143 days. Treatment is less straightforward than in a normal patient with a pericardial effusion, because there's not only the therapeutic aspect, but also often you're trying to get an underlying diagnosis. Sometimes we're unclear of what the cause of the pericardial effusion is. And so a lesson that we've learned the hard way is to ensure that we speak to the oncologist or hematologist before we do the pericardiocentesis, to make sure they tell us exactly what they want the sample sent off for. Because we had one patient who ended up going for pericardial window and pericardial biopsy, and we sent the sample off for what we thought were all the right things. Unfortunately, it hadn't gone off for the correct cytogenetics, and then it was too late, and nobody was very happy. So it's really important to involve your multidisciplinary team when you're deciding what to send the samples off for, and make sure that the cath lab don't just send it off for cytology, MCNS, etc. And then there's a decision, obviously, about whether you go ahead and do a simple percutaneous pericardiocentesis, or whether you do a surgical pericardial window and biopsy. And there's obviously pros and cons of both approaches. From my experience, biopsy tends to have a higher diagnostic yield, and also a permanent, less chance of recurrence than pericardiocentesis. But actually, my clinical experience is contradicted by this paper that was published in the American Journal of Cardiology in 2013, where they found that complications were much higher in patients with surgical pericardectomy, and the diagnostic yield was the same and the recurrence rate was the same. So as I said, that's completely different to my experience, but it's what this paper suggested, which was in 88 patients with cancer who were undergoing either pericardiocentesis or pericardiostomy for pericardial effusions. Does anyone else have experience or thoughts on that?
Yes, Sebastian, are you still on the line?
Yes, of course.
You want to chime in here?
Yes, I have my small comment, because I have own opinion. We prefer, of course, extended pericardiocentesis because we recommend intrapericardial cisplatin treatment with cisplatin, because the efficacy is very, very high, and the patients have the chance, the high probability for next line of chemotherapy, systemic chemotherapy, and the overall survival is the best in our own observations. And I think the quality of life in patients after pericardiocentesis may be significantly better than after pericardiotomy. It's my opinion, of course, from my center.
So you did that paper that you reported on your experience with cisplatin, is that published at this point?
Yes, we have published our findings in journal named In Vivo.
Perfect.
Yeah, I just have a little bit experience with patient. In my life, I had treated many patients, but I had one patient with this pericardial problem, and we did cytology, and we found the cancer cells. So it is metastasis. But at that time, we didn't think about to do pericardiectomy. So I've been taking do the pericardial synthesis for many times. And I think at least like in the first several months, I have to do like once a week, and then I have to do like twice and then 3 times a week. The patient is really suffering. But yeah, we have never thought about to do the pericardiectomy. And the patient is 68 years old, I still remember, and he's a lung cancer patient. So at the end, he's not died of cancer. He's died of the pericardial problem. Yeah, so that's my experience. Just to share with you.
Yeah, Charlotte, I'd like to ask you about if you see a relationship between using checkpoint inhibitors like PD-1 and the early emergence of severe graft-versus-host disease. Has that been an observation?
I haven't observed that, I have to say, but no, I have no experience of that. I don't know if anyone else does.
Thank you.
I have one experience in patients treated with nivolumab and with complications as severe pericardial effusion and severe heart failure, and we used cisplatin treatment, intrapericardial cisplatin treatment in high dose of steroid, and the efficacy was very high. And these patients
So I was going to say, do you think it was the cisplatin or the steroids that did it, that improved that in that patient?
Maybe, but we recommend the combined treatment with high dose of steroids and intrapericardial treatment with cisplatin.
Hello, Ron Krohn. Do you have any comments you'd like to make?
Yes, actually not. I think it's been a great discussion. We generally have been doing pericardiocentesis and just use the window for recurrent situations where we need a biopsy, and they've gone pretty well.
Thank you. Any comments, Maria Santos?
Oh yes. I have just a little question, not just to talk about treatment, because I'm a pediatric cardio-oncologist, I'm sorry. But during the monitoring and since the beginning, just before the transplant, do you think, Dr. Charlotte, that the systolic pulmonary pressure could be a good parameter to follow these patients and maybe make a yellow sign that something strong is happening in the pulmonary system? What do you think about it?
Yeah, I mean, I think that would be useful, although with constriction, your pulmonary pressures are not grossly elevated. So it's your atrial and end-diastolic pressures. You get mild pulmonary hypertension, but it's not. That's relatively late on. I mean, to a certain extent, NT-proBNP is very sensitive for these patients with constriction, and you almost don't necessarily need to do an echo. I mean, I would say for constriction, an NT-proBNP, and then if you're going to do an echo, it's just the simple Doppler parameters really that are the most useful, I think, really, rather than the pulmonary pressures. Because I think my experience is your pulmonary pressure goes up relatively late on, but I don't know what others are.
It looks like the constriction itself prevents high pulmonary artery pressure.
Yeah.
Like about 55 is about the peak I see.
Yeah, but in that second case that you presented, I would say that maybe constriction is not the primary issue there, but rather that pulmonary hypertension would be, just because of the scleroderma-like pattern, and then also the significant RV dysfunction.
Yeah, yeah. No,
I agree. Yeah, I agree. In our pediatric population, the pulmonary pressure is a very big issue for us, and we are always seeing some graft disease involving the pulmonary arteries in the pediatric issues, I mean. So that's why I question this. Thank you.
No, it's interesting.
I completely agree with Dan.
Thelma Rodriguez, do you have any comments you'd like to make?
No, thank you. Very interesting presentation. Thank you very much.
Super.
Tricia
So I was going to present one last slide, which is quite an interesting study, which has just recently been published in, or relatively recently published in Circulation, which looks from the other way around. If you get a patient with pericarditis or pericardial effusion, what's the chance that patient's got an occult cancer? And this was an epidemiological study that was done in Denmark, where every patient's health records are stored and accessible. And there is a cancer registry which has 100% ascertainment. So every patient with cancer is entered on the Danish Cancer Registry. And so it was a data linkage study, and they took every patient that had either been seen in the emergency department or had been admitted to hospital with a diagnosis of pericarditis, and they compared them with age and sex matched controls from the general population. And they found that if you were diagnosed with pericarditis, you had a significantly higher chance of having a new diagnosis of a new cancer, but with an odds ratio of 1.5, so relatively high odds ratio. But that risk was highest in the first 3 months after presentation. And they found that if you were diagnosed or seen with pericarditis in a Danish hospital, you had a nearly 3% chance of having a new cancer diagnosis in the next 3 months. If you had a pericardial effusion as well, you had a just under 10% chance of having a new diagnosis of a new cancer in the next 3 months, which I have to say I was quite struck by, because pericarditis is something that I see, or it's seen the whole time. Nobody takes it very seriously or looks into it particularly carefully in the emergency department here. Patients are generally, if their troponins are normal and they're otherwise well, often discharged home with not much more follow-up. But obviously, if you've got a pericardial effusion, you've got a 1 in 10 chance of being diagnosed with a cancer in the next 3 months. And the age of this population was not that great. So it wasn't that these were all elderly patients who had a high chance of having malignancies. So I thought it was quite an interesting paper. And importantly, and not unexpectedly, it does confer worse prognosis. So if you compare cancer patients who've had a prior diagnosis of pericarditis, their prognosis is quite significantly worse than those who haven't.
Dr. Manistee, in reference to that slide that you just showed, this is Patricia Guerrero. Hi, thank you for your presentation. Are you referring to patients with pericardial effusion without pre-existing history of malignancy? So these are patients virgin to malignancy that subsequently, okay, thank you.
This was they carefully excluded, this was actually, it was quite a kind of systematic study, and they excluded anyone who ever had had a diagnosis of malignancy at any point during their lifetime. So these were complete new, as you say, virgin malignancies. So in conclusion, pericardial disease is common in cancer patients, and we should manage them generally as the normal patient with pericardial effusion. But I think it is important to involve the hematologist and oncologist, not only if you're unsure of what the diagnosis is, it's important to make sure that you're sending the appropriate diagnostic samples off. Immunosuppression may be the first line treatment as opposed to pericardial effusion. If the patient hasn't got pericardial-centesis, if the patient hasn't got tamponade, they often respond quite well to steroids. And it's important to assess patients or know the patient's prognosis when you're trying to decide how to manage them. And then more particularly for patients with allogeneic stem cell transplants, consider constriction, particularly if they've got other organ involvement with GVHD, and pericardectomy may be appropriate in this patient group if immunosuppression or immunotherapy fails. So, thank you very much.
No, that was a superb presentation. Thank you so much.
Pleasure.
Thank you.
Yeah, thank you. So wonderful talk.
Agree. That's very good, Charlotte. And so let me ask you, Charlotte, in patients that, like the Danish study, present with the pericardial effusion and later discovery of cancer, does treatment of the cancer with chemotherapy usually resolve the pericardial effusion in most cases?
That, obviously, we don't have the data from that study because that was just an epidemiological study, so we don't have that data. But I suppose it depends what if it is purely due to the malignancy, then I would have thought so, yes.
Thank you. Charlotte, that was wonderful. That's complete evaluation of pericardial disease in cardio-oncology I've ever seen. We're going to save this production, and it will be posted on Vimeo and today probably. And so I appreciate the hard work that you did putting this together. This is wonderful and great for our students as well as for ourselves. So thank you so much. I appreciate it. Thank you so much for your attendance, Brett, Daniel, Holly. I wanted to also say Susan Dent tried to log on and was basically blocked by the administrator and could not come to the conference, but has been listening but can't comment. So she'll be saving her comments for when we see her at GCOS coming up in about 2 weeks. So we're looking forward to your trip to Tampa and to seeing you all firsthand at GCOS. Thank you so much for your attendance in this conference. And we're actually starting registration for 2019 for presentations, and we'll be circulating that with you soon. And we'll also have it posted at the GCOS booth, at the ICOS booth at GCOS. So thank you so much, Dr. Ping, Thelma Rodriguez, Sebastian, Ronald, Patricia, Maria Santos, Marcelo Cavalcante, Giuliano Segura, Joe Carver, Dan, Holly, and Brett.
Super. Thank you so much, Eric.
Bye-bye.
Bye-bye.
Thank you. See you in time. See you. Bye-bye.
So now, shut